What I might do if anybody wants to jump on, is I would do it. I'll do the one now. I'm going to say that I will do it for break because I have my son's thing at 4:30 and so I wouldn't be home. Okay, so we talked about our algorithm, right? And we were saying for our patients who had comorbidities, we talked about our SGLT2s. So again, newer class of medications, they're going to inhibit your sodium glucose co-transporter 2. And then what that does is it's going to decrease the kidney's ability to reabsorb glucose back into the bloodstream. So again, you think about that mechanism, right? I want to lower the blood glucose that someone has, so therefore they're targeting the SGLT2 transporter to prevent that. So then your patient starts to urinate out more of the glucose, so they're getting rid of the sugar. Clinical use type 2 diabetes, you see that we have epagliflozin and canagliflozin as the two that are specifically FDA approved for the reduction in the cardiovascular risk, but as they continue to do studies, we're seeing that it's more of a class effect. So for the exam, if you see any one of these SGLT2s, you can choose them because we think that all of them in the class actually do give that benefit. These are our ones that ended in flozin, so canagliflozin, epagliflozin, empagliflozin. Don't need to remember the doses, just the drugs that are there. Adverse effects, pretty well tolerated drug. Again, the thing that you're going to hear some of your patients can not complain about, but it's an adverse effect and could potentially complain about, is the weight loss. So that's why you see us use it in some of our patients who do want to see some of that weight loss benefit. Very low risk, again, of that hypoglycemia, especially if you're using it alone. When you add it to things like sulfonylureas or other drugs that are likely to cause hypoglycemia, is when you will see more hypoglycemia with this drug. Hypotension in some of your patients, so we already know that diabetes, we have a lot of comorbidities that come along with it. So if you did have a patient who had hypertension, they can see a slight reduction in that blood pressure, but watch out for your patients who have a low blood pressure because they may be able to, again, get that small reduction as well. So it's not something that we're contraindicated in using it for that reason, but just something for you to continuously monitor. Big thing, and sometimes why we have to stop these medications in our patients. Because of the mechanism of action, right, and I'm excreting now, or I'm getting rid of more, I'm eliminating more glucose. It is coming out in my urethra, right? If I have poor hygiene, if I use the restroom often, if I wear tight clothes often, I am now feeding bacteria and fungus the sugar that they need to thrive and survive, okay? So you will see where some of your patients will have an increased risk of having those UTIs or having fungal infections in their genital area. We counsel our patients. It's kind of a weird conversation, right, to have with somebody to say, hey, like, make sure that, you know, you are wearing looser fitting clothing, make sure that you're cleaning properly. All of those, like, basic things that we talk about to prevent a yeast infection or a bacterial infection is kind of what we're looking at here. So UTIs are a big thing. with these, again, because that glucose is just in the right area and they're just breathing. Okay, so UTIs, fungal infections. Sometimes we can control our patients and help them with this, and they don't have a lot of issues. Some of our patients, no matter what we do, no matter how we counsel them, hygiene, all of the things, they still will get the fungal infections or the UTIs, and we discontinue the medication, switch them to something else. Okay, so that is sometimes something that may happen. And then our last slide that you're looking at, this is just, again, precautions, and for you to know when you can use the medication. So precautions with your clonaglicozin kind of sounds counterintuitive, right? That it has an increased risk of those thromboembolic events, but that risk is or the likelihood of that happening is very low, and we see more of our patients still having the benefit with that cardiovascular risk. So just know that it's something that's there, kind of like make sure that you're monitoring it, okay? And then you see your patients who have any type of underlying diseases. So when you see this erythrocytosis, where somebody has too many red blood cells underlying, like already, monitor their hematocrit. Is not a contraindication. More of us like watching them to make sure that we don't increase that risk too much, okay? Because the higher that count gets, the more likely they are to have one of those events. And then your dapagliflozin, remember that P again, right? Because we're worried again about that bladder cancer. So dapagliflozin has bladder cancer risk with it. Watch out for renal dysfunction. So for this, you have two different cutoffs. You have less than 30 and you have less than 25. If you remember less than 30, we're good. Okay, that's all I want you to know from that. Not going to be super strict on that part of it. But think about our mechanism, right? If I'm increasing how much they're urinating, right? And if they have some type of dysfunction and they cannot urinate, that is why we worry about their creatinine clearance. So we want to make sure that their body is functioning properly to be able to excrete that glucose and eliminate it out, okay? So those were those 3 slides. If you want to go to lunch, you can go ahead and go to lunch. I'm going to start now. Don't record the review.